The last special sense that we have is vision. You guys watching WandaVision? You guys watching that?
Yes,
It's pretty good, isn't it?
it's so good.
It's way different, but it's really good. It's going to set up all the other stuff. I don't know. Geek out on that, but we don't need to record that. All right. Let's get into vision here, because every time I say the word vision, I think of that. I'm just a goofball. All right. We get vision from the light energy in this visible light spectrum. It's just this tiny little region right here. We get to see all the beautiful and wonderful things that we see every day when we get up. Okay. Just a small little part in that electromagnetic spectrum that our photoreceptors, rods and cones, are geared to be able to pick up so we can interpret and understand. To that end, there's a whole heck of a lot of anatomy here. And the first part of this, the first part of the vision quest here that we're going to be doing is all looking at how we are getting those light waves, into the retina. And the retina is where we have all of the doodads, our rods and our cones, that are going to pick up that light spectrum, send it back to the brain to be interpreted in that occipital lobe. But remember, we have three layers, three coats, three tunics. We have the outermost tunic, that's referred to as the fibrous tunic. And I know you know all this stuff, but we're going to review just to make me feel better. We have the vascular tunic, and then we have the neural tunic, which this book refers to as the internal. Usually it's referred to as the neural, because this has the neural cells, the neural tunic. It has the neural cells involved with picking up that light spectrum. We have the sclera and we have the cornea. And the sclera is the white part of the eye. It helps to give the shape of the eye. It allows the muscles to attach into the eye. All those extraocular eye muscles attach into that sclera and help to move the eyeball around. The cornea is just a modified portion of the sclera. It's modified and that it's clear. Allows those light waves to enter in. It does refract the light, so it is a major source of bending this light, okay, which the fluid within all this is going to bend the light a little bit as well. And we're going to try to focus this image, as we're going to find out, on that fovea centralis, that area of greatest visual acuity. The vascular tunic is the middle part. It consists of blood vessels, basically. The choroid is going to be that vascular layer. It's where all the blood vessels are going to be found within. The ciliary body, which is kind of a fancy pants name, and we'll show it off here in a second, is the ciliary muscle and the extensions of the suspensory ligaments from it. That's going to attach into the lens and help to move the shape of the lens to see far or close up. Last part of this vascular tunic, this middle tunic, is the iris. And we know it just as the colored part of the eye, but it's really a lot of various different types of muscles ranged circularly and radially. And it's going to change its shape to allow more light or less light into the center of it, called the pupil. The neural tunic is the innermost layer. Again, this is just really the retina. So it's usually just referred to as the retina. No one usually calls it the internal tunic. But the retina has all the photoreceptors, and this is where all the magic is going to be happening. The lens, technically not part of any tunic. Okay? The lens is what sits right behind the iris, basically, right behind that pupil. And it is what is going to bend the light to get it to focus right again on that fovea centralis. Okay, this is the sweet spot that we always try to get. And you inherently always move your eyeball, your head, or your paper that you're reading. Okay, you're always moving this thing around to try to get it to focus on that fovea. I just had an eye test. I just had my eye doctor appointment last week, and it's fascinating some of the research that goes into looking at, these blood vessels and what they look like. Um, there's a few studies that have come out looking at, you can look into the eyes of individuals. And if we had been there, I have an ophthalmoscope, and we would have looked in each other's eyeballs and blinded each other. It would have been fun and cool. You could see some of this nonsense that we're going to be talking about. But looking at the blood vessels, you can, determine, if somebody has high blood pressure, diabetes, because of what those blood vessels look like inside. There's a few studies that have come out over the last couple years looking at the vasculature of the eye and whether that's indications for some early onset Alzheimer's and whatnot. So there's a lot of cool stuff when it comes to the eyeball, and it really is kind of this gateway, really, to allow you to figure out some very potential nasty things. Alzheimer's is not fun to deal with. But now, aside from looking into the eye and seeing all that fun stuff, seeing the optic disc, okay, which is where the optic nerve is coming in at, they're now doing a lot of computer retinal scans. And they did one for me. And that fovea centralis, it is a pit. It is a obvious depression that occurs within the back of that retina there. And it has a certain depth and shape. And depending upon how deep that thing is some potential indications for potential glaucoma issues. There are some certain long-term vision issues associated with too deep of a fovea centralis, which I something I wasn't aware of. And there is normal variation that occurs, as it does in all anatomy. And mine was a little bit deeper on one side. But so just by that alone, you're thinking, okay, this is potential, vision issues, loss of vision, glaucoma issues, which can compress blood vessels, cause the eye to, start to slowly atrophy and die off. But we compare that with my pressures when they do that puff of air in the eyeball, and my pressures are some of the lowest that are of normal. Okay, if they get too far low, then that means you can have other issues. But my pressures were really low, so it's just a normal variant, and it's just something that we'll monitor over time. There are genetic components when it comes to some of the vision loss issues, long-term vision issues. So there is some genetic components associated with that as well. So again, your longevity of health is a mix of environment and genetics. But when you look at the back of the eye, you'll see a sun, and that's basically the optic nerve. And it has a specific ratio. It's called a cup to disc ratio. And that's something that you can see with just a basic ophthalmoscope when you put it in somebody's eyeball. And if you don't see the disc and you just see a big old cup, again, that's indications of huge amount of pressures exhibiting within the eyeball itself, which can be high blood pressure, can be potential glaucoma, can be a whole lot of issues. So looking into this eyeball and understanding all of this anatomy and what it normally looks like from a diagnosis standpoint, it's really one of the most important things that you could really understand, because it does give you a huge window, if you will, into the health of the patient. Again, I'm probably going to ask a question, essay wise, in the realm of, follow sound waves or follow a photon of light, through the eyeball to the area of greatest visual acuity, during the day or during night. And that's going to get into the retina and the rods and the cones that we'll talk about here in a little bit. But there are a couple words here I want to make sure, okay, that we are all comfortable with, all right? So light passes through the cornea, okay, again, right at the outside, right? And then it's going to pass through the anterior cavity. We have an anterior cavity and a posterior cavity, and cavities are big. Chambers are small, okay? Think of a courtroom. A courtroom is the cavity. You go back to the judge's chambers, and they're generally small. If you've never been, trust me, they're small, okay? So the chambers are going to be small. Cavities are big. Now, they have here, light passes through the cornea and into the anterior chamber. Okay, so anterior chamber is from the back side of the cornea to the front of the iris, if we don't remember. Okay, from the front of the lens to the back of the iris is going to be my posterior chamber. Okay, it's just stuff that's just commonly flip-flopped on an exam, chambers and cavities. All of this region from the anterior, excuse me, from in front of the lens all the way to the cornea is the anterior cavity. So both chambers are in the anterior cavity, okay? Anterior cavity. Oh, okay. So as light passes through the cornea and enters into the anterior chamber, it's aqueous fluid that fills it, but you knew that already. It'll go through the pupil, goes through the center of that iris. Okay? And again, we can change its shape depending upon, how far away it is, the shape of the lens, that is. We can change the opening of that pupil by constricting or relaxing some of the muscles associated with the iris to either let more light in if it's dark, or if it's too bright out, to limit that amount of light in. It travels through it. Once we go through that pupil, it passes through the posterior chamber as it hits the lens, okay? So I don't like how they have some of it worded here, and I just honestly noticed it the other day, okay? So for me, a much more specific way to say this is that as it passes through the pupil, it will pass through the posterior okay? It will pass through the posterior chamber. And then to the lens, okay? Which again, we can change the shape of that sucker depending upon if it's something far away or something close up. After it passes through the lens, after it passes through the lens, light enters the vitreous body. And that's this whole entire posterior cavity here, which you can see they give a super old name, vitreous chamber, okay? It's just generally referred to as vitreous body. It's very, it's a gelatinous goo that you're born with. You're born with that amount, okay? Aqueous humor, the stuff in the anterior cavity, you're constantly making and recycling. And I think we talk about that briefly in a little bit, okay? As it passes through that vitreous body, again, it's darker in nature, so it's going to help absorb some of the excess light, all right? But it's going to allow light to pass through it and then, bam, hit the retina. And then the retina is a very complex thing, and that's what we'll talk about a little bit later, okay? Again, our photoreceptors are there. So again, I'm going to ask, discuss the anatomy involved with getting light to enter into where it hits the spot for greatest visual acuity, and then that's going to be the fovea centralis found within the retina. So if we look at that pupil, If we look at the iris, again, the pupil is just the center of it, right? It's where light enters. The iris, we all know it as the colored portion of the eye. Okay? But I mean, it's more than that. As you can see, it consists of radial muscles and circular muscles. Okay? Circular muscles are inner, and radial are outer. Okay. Depending upon the situation, whether we have dim light or bright light, okay, you can see I get a different type of action from a specific type of muscle. Okay. When we get constriction, okay, circular muscles contract. Okay. This is usually associated with parasympathetic activity. If we dilate that pupil, okay, this is the radial muscles contracting. And this is always sympathetic. Okay? Fight or flight, sympathetic response. Right? If I'm trying to fight something in the dark or fight something anywhere, my pupils dilate. I can increase visual acuity. I'm increasing light into the retina, increasing more light to obviously get on that fovea, but all parts of the retina. This allows me to see my attacker, right? The bobcat in the parking lot, right? So in dim light, okay, we're going to dilate. Okay. In bright light, we will constrict. Okay. This is also going to dovetail with some of the functionality of a rod and a cone. Rods function in dim light. Cones function in bright light. Cones are very sensitive. So I don't need to trigger every dang one of them. All right. I just need to trigger the ones within that pit, within that fovea. In dim light, I want to bring as much light in. It's dark. I can't see as well, right? My visual acuity is low because it's dark, yes, but it's also involving the rods. And the rods are very low vision acuity things. So they need as much openness to bring in as much light as possible, okay? So they can make out, what's in the corner of a dark room because there's somebody over there waiting for me. And I need to open that up. Okay. So we have radial muscles and we have circular muscles. Right. And depending upon the situation, dim light or bright light, we get different contraction of different muscles, and which is different autonomic nervous systems. Sympathetic, open it up, dilate, rest and digest, constrict. Usually that's associated with bright light. The lens, really, the major thing that you really should probably know, it is avascular, okay? Which is why we can transplant those things with relative ease. Compose a living cell. Okay, I don't really care about that. It is attached to muscles that are called ciliary muscle. Ciliary muscle, and I think I have a picture on the next slide that shows that off. And it's being held in position by what are called suspensory ligaments. Cataract is just the cloudiness that can develop on the lens because of too much UV exposure or diabetic retinopathies, whatnot. So here is the ciliary muscle right there. And there are the suspensory ligaments, okay? Zonular fibers of suspensory ligaments. Just call them suspensory ligaments. Who cares, okay? Unless you're going to be a ophthalmologist, okay? Then I imagine you'll do a little bit more schooling than just here, okay? So the ciliary muscle and the suspensory ligaments collectively are my ciliary body. All right. Ciliary muscle is going to contract or relax, and that's obviously going to change the shape, the tug on the lens by those suspensory ligaments, which will change the shape and allow me to see, close up or far away. And it looks really weird, and it's kind of counterintuitive for how it, you would think it would function.
Stuff is flipped, right?
Yeah.
Or am I thinking of no? That's right, isn't it? Yeah. Because I remember doing some of this in anatomy. We looked at like if it's far away, it's like upside down and like backwards and like mirrored, and your brain sorts that all out. It's really cool.
It is. Everything hits it backwards and upside down. And then your brain flip-flops it around. There's actually glasses that you can wear that'll flip-flop everything for you. And it is fascinating because obviously in the beginning it's very disorientating because everything's upside down and backwards. But eventually your brain is weird. Eventually, if you wear those long enough, you get used to that, and your brain will slowly adapt to it and realize, okay, I got to shift it. And when you take those glasses off, and then everything's backwards and upside down again, and then it'll take a little while for you to get used to that, and then eventually your brain will adapt. So there's glasses. I don't know if we have some. I thought we used to in the lab. I can't remember, but they're funky. I think you can find them probably somewhere on Amazon, probably.
So you said the ciliary bodies are just made from ciliary muscles and suspensory ligaments?
Yeah, the ciliary body is just collectively the
just those two things together.
Yep, and the ciliary muscle combined. You bet.
Okay.
One of the major functions of the ciliary body, obviously besides changing the shape of the lens, is creating this aqueous humor. Okay? It is what fills those two small chambers. It is clear. Okay? It is clear. It does, aside from being a refractory type of thing, so it helps to bend the light a little bit, it does contain sustenance for the cells that make up the lens, make up the cornea itself. So it does provide some nutrients in that regard. Excuse me. I'll go here to a picture. Okay. So here again, here's that ciliary body. Again, it's just a collection of the muscles and the suspensory ligaments that extend off of it there. This right here is my iris. So the ciliary body produces this aqueous fluid. And it just floats here, kind of goes into the anterior chamber, floats around. But here I have this, I love the canal of Schlemm. I mean, how cool is that name? They're changing. It's called the scleral venous sinus. Okay. This is the little tube, the opening, the sinus, that helps us to drain the aqueous humor from the anterior cavity. If that is blocked, I don't have a way to reabsorb that aqueous humor. And that leads to a buildup of pressure in there. That's referred to as glaucoma, right? And I can displace the placement of that lens. If I move that placement of the lens because of all of that fluid increased, then obviously I'm not going to be able to put the image right smack dab on the retina. And then that's going to create a severe amount of distortion in that image. Okay, so inadequate drainage leads to glaucoma. There, scleral venous sinus is what drains the aqueous humor from the anterior and posterior chambers of the eyeball. Reabsorb back into the blood, and you are constantly remaking this stuff, right? Which is different from the vitreous body. Vitreous body, you're basically born with. Okay. There are a few different types of glaucoma. I think the book gets into it. I'm not going to get into it. All right. If we have too much pressure being built up, that will displace the lens. If that pressure continues to build up and we continue to displace that, obviously this is going to push back on the vitreous body. which can push back on the retina. And specifically, what I'm worried about is compression of that optic nerve. Okay? If I damage that optic nerve, what am I compressing? I'm compressing these blood vessels as well. So not only am I inhibiting some of the nerve fibers from those ganglion cells that we'll soon see in the retina that extend that electricity back towards the optic nerve, therefore preventing us to see an image clearly. But I'm also compressing, as you can see there, my artery and vein. So again, if I'm going to limit blood supply to the cells here, I mean, what's going to happen? Obviously, stuff's going to start to die off. All right. So this glaucoma is a pretty serious thing. It's a pretty serious thing, especially if you have a family history of it. I believe there's a family history which goes into the genetic component associated with some vision issues. Okay. If the vast majority of your family issues, though, is like, grandmas and grandpas that are diabetic and having vision issues, then, I mean, that's not necessarily going to be you. Okay. Unless you sort of
Dr. Thorne?
diet and continue that diet on. Okay. Because I know I've had grandparents who all had some glaucomas, but I mean, they all ate like crap. Somebody have a question?
Yes. So how does the weed plant help with that? Because you know how like some people be like, I'm you know, taking my weed plant for my glaucoma, but how does that help with any other pressure?
Um,
Probably helps with the pain more so than the pressure, I'd imagine.
well, I don't know exactly the specific mechanisms for helping to relax some of the tissue up there. I don't know if it is helping with to relax some of the compression that occurs here within the sclerovenous sinus. Sometimes this can become obstructed for some reason. And if that hole can become obstructed, that will obviously lead to that buildup. So if I can relax, and again, it's those cannabinoids that are there with involving some relaxation of various different areas of the brain, activating areas of the brain, triggering the feel good chemicals. It's also going to be, it's also going to help diminish some of the sympathetic effects, some of the contraction and constriction and various different things. So it helps with relaxation. And so if I relax the soft tissue within here, and some of the mechanisms we just don't fully understand with those cannabinoids, especially those endocannabinoids, the ones that we make. But it can, if you can relax some of the pressure within the tube that's caused within the soft tissue there, that can potentially help to increase the drainage and help to prevent the glaucoma. Okay. Yeah, if you're going through and reading some of this stuff too, the book tells you flat out, this is the mechanism, this is what happens. I don't know we don't know the stuff that happens in between to cause A to B to C to D to get the E. We know that this does something, and we know that this is always a direct result from this thing happening. But some of the specifics we just don't know yet, which to me, I find that's the most fascinating thing in all this stuff. I keep talking about this refraction. It's just the bending of light. Okay. The greatest amount of bending of light, focusing light, if you will, occurs at the cornea. Right. That's where our greatest amount of bend occurs. And the picture, I think, definitely shows that off. All right. But we have our greatest amount of bending that occurs there. The fluids also create a little bit of refraction as well. So the aqueous and the vitreous humors, they will contribute a little bit as well. to the bending of the light. But this bending of the light is necessary because it allows us to bend the light to get it to go to the lens, to the pupil. By getting this light to bend and go into the pupil there, I could then focus this light back onto the retina. Specifically, I love to try to get the light, the image I'm looking at straight ahead of me, getting that on the fovea centralis. Again, that's going to be our greatest visual acuity, all right? And again, like Sam chimed in earlier there, it's always flip-flopped and backwards, okay? That's just how it does, okay? It hits that medium there, air to cornea, and then the cornea to the fluid. When it hits these fluids, it flip-flops it. And the cool thing about not even that, in that our brain, our occipital lobe, flips it back around and turns it back around in the right direction so we can interpret that. But even the eyeballs themselves, when you look at the retina, there are two major regions associated with it. And they don't really have a name or a moniker, but they do occur. We have different areas of the retina that pick up different specific regions of the visual field. As you can kind of see here, ultimately everything on the left is collected and passed to the right side of the brain. Everything on the right side of the field of vision is ultimately collected and shuttled over to the left side. So just like sensory sensations on my left is interpreted on the right, okay, and motor commands are for the most part interpreted on the opposite side of the brain, the same thing here for light with this sense. As you can kind of see here, we have what's referred to as a temporal portion of the retina and a nasal portion of the retina, okay? And when you're in the ophthalmist office, the eye doctor's office there, okay, when they're, going all around and, is it number one or number two? And then they flip it around, number one or number two. They're looking at all of the retina there to try to determine if your eyeball is properly shaped. Okay, if it's odd shaped, then, that leads us to the astigmatism, which obviously causes a blurry image. But here, as you can kind of see, everything on the left side over here hits on the medial side, hits on the lateral side. And as you can see, stays and crosses over. This area right here where we cross over these various different optic nerves is called the optic chiasm. And then it continues back as the, optic radiation, basically. But here, I'm collecting all of that left field of view and I'm going to the right side of the brain. Same thing for the right field of vision, okay? You can see it on the nasal half and on the temporal half of the left eye. So, if we have, tumors in this location, you can see how it can affect peripheral vision. If we have tumors back here, it can affect a specific eyeball. If you have one smack right down there, it can affect your tunnel vision, and you can only see in the periphery by just compressing those various different nerves. To me, this is the coolest aspect here. Okay? So you can be really specific when if a patient comes in and complains about, having vision issues in a specific field, like, if they're looking straight ahead, I can't see over here. Okay, so is that this eye or is that this eye, the left eye or the right eye? Okay. And you can test the cardinal fields of gaze and you can assess that type of thing. Somebody have a question?
Yeah, is that kind of like with depth perception as well?
A little bit. Depth perception is going to deal with basically monocular or biocular vision, okay? And if we are completely compressing this, then we are completely getting rid of, obviously one side of the vision spectrum there with an eyeball. So And there, that
Mm.
would obviously affect depth perception. Okay. The last thing here in terms of getting this light ultimately into that retina here is accommodation. And accommodation, all it is our ability to accommodate the movement of an object and to be able to focus it on the retina. Okay, so if something is close and then far away, is close and then far away, okay, that's going to change the shape of the lens accordingly. Okay, and that ability is referred to as accommodation. So when the doctor is doing those cardinal fields of gaze and going in all the planes there, then they have, you say, watch your finger, and and then they're going to watch your eyes basically cross. They should both cross at the same time. Okay, so as this doctor is like making you sick by going back and forth, all right, they're looking to see, are the eyeballs converging on the image as it gets closer?
Because if they
Equally.
don't, isn't that like lazy eye or something?
Well,
Or that could be a reason.
it could be. Lazy eye is more associated with one of those extraocular eye muscles not functioning properly, which, I mean, that could be an issue. But with true accommodation, it's more of your ability to change the shape of the lens for your vision properly. So if you go in and you can see, if you can see far away, but you can't see close up, you probably have more accommodation issues. If you can see close up, but can't see far away as well, it could, accommodation isn't something that's going to affect you because you can see really close. So your eyes are going to easily converge. If you have a misshapen eye with astigmatism, it's usually a misshapen eyeball. It could be a misshapen lens, but usually it's a malformed eyeball. And I say it, and that sounds really bad, but I mean, a lot of people have an astigmatism with a misshapen eye. It's just not optimal. Okay, it'll be either skinnied or elongated for whatever reason. That's when you're going to see a heck of a lot more issues with this accommodation, with this ability to see stuff close. Okay, because if your eyeball's misshapen, okay, if it's widened out or flattened out, that lens is going to have a real difficult time getting that image to focus properly on the retina. Okay, and so that's where you see that. If a kid, when a kid gets born, that's generally when you'll see a lot of potential lazy eye issues, especially as they get older and start to be able to focus on stuff. That's where the pupils don't line up and one kind of wings off to the side. You can wear special glasses to help strengthen the muscles. You can do you could do Botox into the muscles, but a lot of times they will just do surgery, especially if it's severe enough. They will do surgery, and they do this relatively young because this will affect their learning capability because they won't be able to focus at all. It'll be monocular vision a lot of times. So their coordination skills, their motor skills are going to be slower to progress and develop. Learning is obviously going to be greatly affected as well. So getting that in and fixing that vision is going to be a major thing. I have a friend, she had her daughter had a really bad lazy eye, and I think she's like maybe 3, 4, something like that. And they did surgery. One of my brothers, their son had a lazy eye, and they were able to wear the special glasses and get a lot of adaptability and to strengthen up some of the other muscles to accommodate. So I can't remember if he ultimately did, but I know they wore that special lens for about a good year. But it takes some time to help with that lazy eye. With accommodation here, to change the shape of the lens, again, we're involving that ciliary muscle. okay? When we contract the ciliary muscle, I can see close up. When I contract those ciliary muscles, it's counterintuitive. The suspensory ligaments relax. Okay? So here I have contraction of the ciliary muscle here. It looks like a big old fat tire, doesn't it? When it contracts, it actually loosens up on these suspensory ligaments here. To me, I use this visual, okay? This thing gets closer, this thing. The ciliary muscle gets closer to the lens. So as it gets closer to the lens, this ligament distance gets less.
It's like a rubber band.
Yeah, okay, exactly. And so this allows this lens to get really, rounded up, thickened up. And this allows me to see close up. And it's just the exact opposite for distant vision, okay? For distant vision, we get relaxation of the ciliary muscle, okay? This causes these suspensory ligaments to basically be pulled tight, constricted. And this thins out the lens and allows me to get that image to focus on the retina properly. There is, as stuff gets further away, there is less bending that occurs. The closer it gets to the eyeball, the greater the bending, the greater the refraction occurs there. Okay. So to thin out that lens allows me to bend this thing to get directly onto the retina. If you can't see far away, okay, then you have an issue. And that's where we have to correct that with lenses, various different specific shapes, various different specific sizes, okay, to help get the image to focus properly on the retina. Myopic and hyperopic vision. Okay?